Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. In today's episode of 1 p.m., Jason will be talking to us about chronic kidney disease. Take it away, Jason.
Okay, so today we'll be talking about chronic kidney disease. So, CKD, does anyone know what that is?
Let's pretend I don't know, Jason. No, you know what? I know. But let me see if you know.
Derive it from the word.
Let me see what you know. Do you know what CKD is, Jason?
Okay, let's begin by going through the first principles of CKD. So in order to understand CKD, I feel that we need to understand what the three basic kidney functions are.
Sure.
Okay.
So what are the three basic kidney functions?
Well, first,
let's go, JT.
It's to help filter our blood of all the waste that we produce and excrete it out of our body in the form of urine.
Yep. Regulates our fluid levels in the body? Or does that count under the same thing as JT? Or is that separate?
Yeah, like filtering and then regulating fluids kind of one.
Separate, okay.
Yeah.
And thirdly, I believe it does produce some endocrine hormones.
Yeah.
Is that the three that we're looking for?
That's three? Okay.
Yeah.
Okay, nice.
I've kind of labeled them to make it a bit more clearer. So the first function is regulating concentration.
Okay.
The second function being excreting metabolic waste products. And the third function being hormone synthesis.
I see.
So under regulating concentration, what are three things the kidney regulates in terms of concentration?
Sodium?
Yeah. So it's sodium. When you regulate sodium concentration, what else do you regulate as well?
Water,
right?
Yeah.
Water follows salt.
Yeah. So as JT said, water follows salt.
Yep.
So I kind of lump those together as one of the concentrations which the kidney regulates.
Sure.
What's another one?
I don't know if this counts as the metabolic waste, but urea? Is that
I've kind of put that under the metabolic waste products.
Okay.
We'll go to that later.
Other electrolytes, potassium?
Yes. So
Okay.
electrolytes, right? That's another category of things which the kidney regulates. So electrolytes and salt and water. Now, what's the third one?
Acid base.
Acid base, right?
Yeah, acid.
I see.
So the three things the kidney regulates in terms of concentration are sodium and water, which are kind of considered one thing, acid base, and electrolytes, so particularly potassium. Okay.
I see. Yeah.
Now let's go to the next basic kidney function, the excretion of metabolic waste products.
Yep.
So JT already mentioned one, urea.
Okay.
Things like uric acid, creatinine is another. And the last thing I've included in that subsection are drugs.
Okay.
So in regards to hormone synthesis, there are three main hormones the kidney secretes. Can anyone think about what they are?
Erythropoietin.
Yes. And what is erythropoietin or EPO's function?
EPO increases red blood cell production.
Yeah. So
And
it stimulates the production of erythrocytes or red blood cells in the bone marrow.
Helps Tour de France winners.
So generally, I just want you to think of EPO as equaling hemoglobin control.
Sure.
Okay? So red blood cell control.
Yeah.
So what's another hormone?
Cortisol?
No.
Adrenaline?
No.
It's adrenal gland.
It's adrenal gland.
On top of the kidney, though, I'll give you.
It's close, but
It's the
two others.
renin.
Oh,
Renin.
yeah, the
Renin.
RAS system.
So what actually is
Oh,
The renin-angiotensin system is involved in fluid retention and the long-term control of blood pressure.
Yeah, so what you need to know is that renin equals blood pressure control.
okay.
And a more in-depth understanding is that renin promotes the conversion of angiotensinogen, which is produced in the liver, to angiotensin 1 or AT1. Then that activates the renin-angiotensin-aldosterone system, commonly known as
RAS.
And that leads to sodium and water retention, which leads to blood pressure control.
Yeah.
So we've got renin, EPO, last one. Come on.
Calcitriol.
Calcitriol.
Yeah.
So calcitriol is the active form of vitamin D3.
That's the one.
So I'll just quickly go through the physiology of that. So the kidney converts 25 hydroxy vitamin D3 from the liver, known as calcidiol, into 125 dihydroxy vitamin D3, calcitriol.
Yeah.
Okay.
I love how you can say that perfectly, but you can't do the intro to this podcast.
I get stressed out.
Can you say irregularly irregular?
Regularly irregular.
Hey, you got it.
Okay. And does anyone know what the function of vitamin D3 or calcitriol is?
Uptake of calcium? No.
Yeah. JT's on the point. So calcitriol, it increases the calcium absorption from the small bowel and renal tubules, and it also increases calcium release from bones. But all I want you to remember is that calcitriol equals bone health.
Okay.
So can you guys repeat to me the 3 hormones and the 3 main functions of them?
So EPO for red blood cell health, and then calcitriol for bone health, and then renin for blood pressure health.
Simple,
Health.
right?
Simple. 3 health.
Okay. That's all you need to know about CKD,
All right.
in my humble opinion.
Love it.
Okay.
Love it.
So now that we've gone through the 3 basic kidney functions, we're going to go through the definition of CKD. So does anyone have any definitions of what CKD may be?
I know there's 2 ways of looking at CKD by the kidney disease guidelines. One is them with albumin, and the other one was with filtration rate.
Yeah. You're on the right line. So the first definition of CKD is when you've got a GFR, which is glomerular filtration rate, less than 60 mils per minute for greater than 3 months, with or without evidence of kidney damage. So that's just the GFR one. And then you've got the other one, which is evidence of kidney damage. For example, things like albuminuria, hematuria, for greater than 3 months, with or without a reduction in GFR. Okay? So one's like GFR, and then the other one's kind of like evidence of kidney damage.
Right. So, for example, could you think of it GFR, like you see it as a diagnostic test, you see GFR, and then the other one you see as signs and symptoms, the albuminuria. Is that?
If that helps you, I
that
just
helps
kind
me.
of think one's
It could be
evidence of kidney
albumin or
damage.
hematuria or something else.
Yeah, one's evidence of kidney damage, the other one's just using GFR.
Yeah.
But usually a combination of both would happen if someone has some kidney damage, right?
Yeah, gotcha.
And CKD can be broken down into various stages, as we probably heard before, like stage 1, stage 2, all the way to stage 5.
Mm-hmm.
And those are usually based off the GFR. For example, a stage 5 has a GFR less than 15. Okay, but you can just look at the table which is on the Notion document. Then there's also criteria based on how much albuminuria there is.
Here's a bit of trivia, I guess. You see a patient with stage 5D, chronic kidney disease. What does the D stand for?
Death. Dialysis.
Dialysis, I think, yeah.
Which is a precursor to... No, I'm just kidding.
Pretty
It's
much
really
is, yeah.
morbid.
Okay, and what are the common causes of CKD? And there's only one I really want you to know. What would be the most common cause of CKD?
Poor blood pressure health.
That's the most broad statement
You-
ever.
you mean
I was
like-
going to say hypertension.
You mean hypertension?
Yeah.
That is one of the causes, but
Oh, no,
causes,
the other
but
one
that's
is-
the 4th one according to my
Okay, diabetes.
Sugar.
diabetes, right? And what do you get from diabetes, which is a common kidney dysfunction?
You get
Diabetic nephropathy.
Yes.
Yeah.
So diabetes is the most common cause of CKD.
Oh,
Yes.
okay.
Okay.
What was the
Other-
second one?
Other ones are like interstitial diseases, glomerular diseases.
Also
like-
within the kidney already.
yeah.
Yeah,
But
I see.
I just want you to remember diabetes, right?
But say,
Sure.
for example, you on a ward round and consultant asks you, all right, just give me 3 big causes for CKD. What big 3 would you choose?
So you've got diabetes mellitus, interstitial diseases, which are often caused by like adverse drug reactions.
So interstitial diseases of the kidney? Sure.
And glomerular diseases. The most common one is IgA nephropathy.
Okay.
And then the 4th one you probably want to include is hypertension.
Yeah. I think I'm going to move hypertension to the second
Yeah.
one because I remember that one.
Okay. So now that we've gone through the first principles of
Mhm.
CKD,
Mm-hmm.
we're going to think about what are the common complications of CKD.
Mm-hmm.
And we're going to break down the complications in regards to the 3 basic kidney functions.
Yep.
Okay. So if the kidney's function of regulating concentration is affected, what are 2 complications you could foresee happening?
So if you can't regulate your fluid concentration, you become fluid overloaded, potentially.
Yes, fluid overloaded, or there's more volume equals
High blood pressure. Yeah,
hypertension.
yeah.
So the inability of
Yeah,
the
yeah.
kidney to regulate the salt and water balance
Yes.
equals
Hypertension.
Hypertension.
There you
hypertension,
go.
right?
Yeah.
Yep. So that's an easy one to remember, right? Now, what's another one?
The electrolytes or whatever?
Yes.
Okay.
What particular electrolyte we like to think of?
The potassium.
Yeah.
Bananas.
So what could you get?
Hyperkalemia.
Yeah.
Hyperkalemia.
Because you can't excrete it.
Yeah, the kidney's ability to regulate concentration's messed up. So there's impaired tubular excretion of potassium, which leads to a rise in serum potassium or hyperkalemia.
Would you know why there's no hypokalemia? Or is that...
Well, the kidney usually excretes potassium, so therefore the kidney's ability to excrete is not really
I
working
see,
well,
yeah.
which leads to a buildup, right?
I see. Okay.
So under regulation of concentration, we've got hypertension and hyperkalemia.
Yeah.
Okay. So now moving on to the excretion of metabolic waste products, there is one complication which is common. Can anyone?
Uremia.
It's associated with the urea.
Acidosis?
Yes. So you get a metabolic acidosis, okay? Because if you can imagine, CKD patients, they accumulate a lot of waste products. And the way I kind of view it is that basically there's reduced excretion of hydrogen or acid, okay? So now in regards to hormone synthesis, you get two complications. Can anyone think of anything?
Yeah, reduced production of EPO.
Yeah, and what would that result
The
in?
result of that is reduced production of erythrocytes, which leads to anemia.
Anemia, okay? So the insufficient EPO production is part of it, but there's also end organ resistance to EPO, okay? So that's actually one of the main reasons why.
End organ, you're talking about bone marrow resistance?
Yeah, I think so.
Okay.
So it becomes what? Less sensitive to EPO? Is that right?
Yeah, I think that's what Neil tried to write. I didn't really understand it, but
This has been
he
fact
just
checked
said
by
Read the
end organ
document.
resistance to EPO,
Right.
which I think that's the understanding.
This document has been fact checked by Professor Neil Bouville.
And it's an important thing to know because he mentioned that EPO levels can be normal or even elevated in CKD patients. And some people get the impression that measuring EPO levels can help them decide when to prescribe EPO in CKD patients.
Right. So as in,
Wait, why will it be increased?
Sorry?
Why would I thought the kidney can't function well, so it can't produce EPO.
Yeah,
no?
but if you're like flogging a horse or something to produce more
Yeah.
EPO and then the bone marrow is
yeah.
resistant to
Oh,
negative
it.
I
feedback.
see. I see.
there's
I
a
see.
lack of negative
Yeah.
feedback.
So,
Okay.
so that's why he made that point because there may be a lot of people who measure the EPO levels
Yeah.
and look, oh, it's normal.
Yeah.
Therefore,
The kidney's
that
fine.
can't be the kidney's fine or
But
whatever.
it's not.
Yeah,
Yeah.
it may be the case. But sometimes there are cases where there is insufficient EPO production as
Right.
well.
I
So-
see, I
But
see.
I'm not a nephrologist, so I don't really
So
understand.
could you think of it like if there's direct damage to the kidneys impairs the ability to produce EPO.
Yeah.
However, if you have a situation where the end organ, in this case bone marrow, becomes resistant to EPO, you have reduced negative feedback onto the kidneys, so the kidneys then produce more EPO to
Yeah.
make up for it. So if you measure and you see elevated EPO, it actually doesn't tell you whether the kidney is injured or not.
You could be right or you could be wrong. I actually don't know. But that sounds right, right?
Sounds like something you should have
Sounds-
asked Professor Neil.
Okay. And you get a normocytic anemia.
Is that because you're just not producing enough red blood cells, but the red blood cells you're producing are the
Normal.
right size?
Yeah. Now, what's the other complication you can see with hormone synthesis?
Vitamin D stuff.
Yeah, bone stuff. That's a hint. There are like 3 different
Yeah.
things working at once, like
Yeah.
3 or 4 different things. So
Yeah.
I'll just tell you. It's hyperparathyroidism. So the 3 mechanisms which I kind of identified were that you get phosphate retention, okay, because your kidney can't filter out the phosphate as well.
Also, you get hyperphosphatemia as
Yeah,
well.
so that leads to high serum phosphate, and then that increases PTH secretion,
Sure.
okay? You've also got a second mechanism, which is calcitriol deficiency, because less calcitriol is produced. That leads to reduced calcitriol inhibition of PTH.
Yeah.
Okay. And the third one you get is that you have low calcium, and then that leads to increased PTH
Yeah.
secretion.
I'll remember maybe 1.5
Yes.
of those.
And the reason why I mentioned that is that serum calcium can be normal throughout, but PTH will rise due to the other mechanisms.
Right. Okay. Yeah. Because the increased level of parathyroid hormone compensates to normalize your calcium level.
Yes.
Right.
But you can still have high PTH even with the normal
Exactly.
calcium
Because
of all those
yeah.
other mechanisms.
So you'd have normal calcium because you have high PTH, because the PTH increases calcium release from the bones. So it normalizes your calcium.
I think what I wanted to demonstrate was that the hyperparathyroidism is almost independent of the calcium levels because you've got those other mechanisms of calcitriol deficiency and phosphate retention.
and that trumps
Because usually parathyroid hormone responds to the calcium levels,
Yeah.
but because you've got the phosphate retention
Mm.
and calcitriol deficiency, those things can take it off balance.
Sorry to labor the point, but isn't it that because parathyroid hormone increases calcium release from the
Yes.
bone, right? So if you have low calcium from these reasons,
Yeah.
the low calcium is picked up by the parathyroid gland.
Yeah.
Parathyroid responds to this by increasing release of parathyroid hormone. Parathyroid hormone then increases calcium release from the bone to bring your calcium level
Yeah.
back up.
But
Sure.
anyway, hyperparathyroidism.
Okay,
That's all.
yeah.
Done.
Cut
Okay?
it out.
Done.
Yep.
Okay. And the last category, which we haven't discussed, are the multifactorial complications. Okay?
Right.
And there are two main ones. Can anyone think of them?
Heart.
Heart. right?
Cardiovascular.
Yeah.
So there's a significantly higher cardiovascular disease risk.
Yeah. Well, hypertension is one.
Yeah, hypertension, but all I'm saying there's a bunch of different shit
Yeah,
which
sure,
goes
sure,
on,
sure.
which increases your risk of
Yeah.
cardiovascular disease.
All these hormone
Okay.
imbalances.
Yeah. What's another multifactorial complication? So if you've got CKD, you're
Yeah.
at higher risk of
Infections.
what do infections do to the kidney?
Nephrotic disease, nephritic
So
disease.
increased risk of and
UTIs.
acute kidney injury.
Ah,
Right?
it's okay, sure.
Because you've got to reduce
You
vein
misled
lo-
us a little bit
Yeah,
with the
okay, sorry.
multifactorial thing.
Yeah,
It's
that's
just,
what I mean. I really
literally a
should-
kidney. It's literally the kidney.
specific. I don't know where to put it under though. Okay, I'm confused. I'm trying to just
kidney.
categorize.
So this
it.
is AKI on top of CKD.
Yeah, just
Acute on chronic
All I want to
kidney
say
injury.
that you're increased risk of an AKI because your baseline renal function sucks.
Sure.
Okay, so anything can push you over to an AKI.
Yeah, gotcha.
Does that make sense?
Makes sense.
Okay, so those were the 1, 2, 3, 4, 5, 7 complications, right? Of CKD. Nice and simple, right?
Do you wanna go over it, Jason? Give us
No.
a summary so far.
How about you give me the 7 complications?
How about I give you?
All right, JT, you give.
Okay,
you give
what-
6. I'll give 1.
Okay, what are the 2 complications regarding the regulation of concentration?
So you get poor regulation of blood pressure, hypertension.
Yeah. What
Just
else?
give you the name. The other one,
Metabolic acidosis.
Yeah, that's under
That's under
metabolic
the wrong
waste products,
category.
but yeah, it's similar to regulated concentration. What's the third one?
Kalemia.
Hyperkalemia. Yeah.
and hyperphosphate.
Temia.
PTH.
Yeah. That's hormone synthesis, hyperparathyroidism. What's another hormone synthesis?
Oh,
one?
you get anemia.
Anemia?
Yeah, that's the other one.
And then the multifactorial one
HKI.
and
Heart
stuff.
heart
CVD.
disease. Yeah, thank you.
Yeah.
So now we'll move on to the management of CKD. Okay. So with any management question, you can always break it down into 2 simple
Pharmacological
categories.
and non-pharmacological.
Or non-medical and medical.
Yeah,
That's
sure.
the way I view it. Okay, so we'll start off with non-medical first.
Yeah.
What is the general category of non-medical management?
Here we go. Say it,
Patient
Adian.
education.
Yeah, or lifestyle advice.
Lifestyle
or patient
management
education.
via
I say
patient
lifestyle
education.
advice, okay?
Yeah.
And there are 5 main things which you can include under lifestyle advice. What are those? Come on.
Let's
This
go.
will be
With the
easy.
blood pressure,
Yeah.
minimize salt, minimize water. Oh,
Yep,
actually,
so,
just minimize salt.
under
I think, yeah.
dietary advice,
Yeah.
you want to tell them to reduce their salt intake, reduce their calories, like a lower fat diet. Okay? So what are the other lifestyle advices which we always see?
If there's smoking, stop
Yes.
smoking.
Smoking cessation,
Yeah.
sound fancy?
Control your diabetes well with
That's under medical. We'll get to that. Diet,
What?
smoking cessation.
hey,
What else?
you can watch what you eat.
Yeah. Now, I guess it goes
Okay,
both.
yeah,
It goes to both
yeah,
your
yeah,
CKD
sure,
and your
yeah.
diabetes.
Anyway, I'm
right?
just trying. Dietary advice, smoking cessation. What are 3 others?
Exercise.
Yes, exercise, increase
Exercise.
physical activity.
Yeah,
What else?
yeah. Alcohol.
Yes,
Reduce
reduce
your
alcohol
alcohol.
intake. Come on,
Yeah.
these are like the most simple
Yeah,
ones.
yeah. Weight loss.
Fucking diabetes.
Yeah, I'm gonna
Fuck
go
you.
through that in medical management, man.
No, weight loss is diabetes.
No, there's both. There's both.
Fucking hell.
You can't just cure diabetes exactly with.
Yes, you can. Fuck the
I'm
medications.
sorry. Okay.
We are not doctors. We are medical
God,
students.
JT, man. Far out.
Please,
I'm just annoyed.
please consult your
Yeah,
health
well-
practitioner for actual medical advice.
Okay. So now the fun part, the medical
All
management.
right, JT.
Diabetes.
Shut up. Just stop fucking shouting. Jesus
Explode my
Christ.
microphone.
Okay. Medical management. Okay. There are 3 management principles. Okay.
Yeah.
Can anyone think of what those are?
Control your diabetes.
Yeah, that's a subsection of one of them. Okay.
Reduce your blood pressure.
That's another subsection. Okay. Do you want me to go through these?
Wait,
Okay.
just
No,
give it-
no,
just-
no. What are you categorizing
No,
this
give
by?
us-
Like
give us-
very broad categories of,
Of-
managing CKD.
But as in, are these like broad categories of medications?
No.
Medication
they're
is
just
one of them,
broad
right?
titles. So I'll give you an example.
Pharmacology.
One's like slowing what progression.
Ah, okay. Go, JT.
Slowing kidney disease progression.
Yeah. So slowing chronic kidney
Yeah.
disease
Asshole.
progression. That's one. What's the second one?
Controlling diabetes.
minimizing complications.
No.
Yeah. So monitoring for CKD complications.
There you go.
And what's the third one?
Controlling comorbid conditions.
No. Reducing
Reducing
risk factors of what disease?
Cardiovascular disease.
Yes. Okay. So think about it in an OSCE. You'd want to say, I'd want to manage their CKD progression, control their cardiovascular risk factors, as well as monitor for CKD complications. See how fancy you sound?
That's actually pretty
JT?
good.
Lovely,
Shut the
yes,
fuck
yes,
up, JT.
yes.
That's pretty good. That's pretty good. I'll give you that. That's pretty good. That's pretty good.
So now that JT has allowed me to speak clearly, okay? So under slow CKD progression, there are 4 things you'd want to do. Okay, so JT mentioned one, diabetes management or glycemic control.
I never thought to hear this.
So we're just gonna touch on this broadly. Yeah. So for glycemic control, you want to aim for an HbA1c of
7.
approximately 7%.
Yeah.
Okay. In general, for type 1 diabetes, you need insulin therapy, and for type 2 diabetes, you want oral hypoglycemic agents.
Anti-hyperglycemic agents.
Oh yeah, anti. Okay. What's another thing to slow the progression of CKD?
Manage their hypertension.
Yep. So blood pressure, hypertension management.
I actually thought that would be under cardiovascular risk factors.
Spoilers, there is some overlap.
Yeah,
I'll go through
fair
that.
enough,
Okay.
fair enough.
So under blood pressure control, what blood pressure do you want to aim for? Give me systolic and diastolic.
130.
Yeah, so less than 130
On
over
80.
So less than 130 on 80 is the blood pressure you want to aim for. And in general, what is the first line therapy for blood pressure management?
ACE inhibitor usually.
Yeah, and they may need combination therapy if they're unresponsive to blood pressure management. And what are those add-on therapies?
Calcium channel blocker.
Calcium channel blocker or thiazide?
Diuretics.
Yeah.
Okay, there's a third one. You want to reduce the proteinuria.
Oh, yeah. Yeah.
But interestingly, you reduce the proteinuria with the drugs you use for blood pressure control. So basically, ACE inhibitors or ARBs actually help to reduce the proteinuria. Okay? I'm not actually sure what the mechanism is for it, but ACE inhibitors or ARBs are the drugs which are used to reduce protein. And they're prescribed to patients with diabetic nephropathy and or proteinuria, irrespective of whether or not hypertension is present, because they help with the proteinuria. Okay? And the last drug, which I swear to God, this is like a wonder drug now because it's used in heart failure, diabetes.
Give me, let us
Come on. Heart failure and type 2 diabetes.
SGLT2I.
Yeah.
Yes.
Yeah.
SGLT.
Gliflozin or whatever.
Yeah, the flozins. Okay.
Gliflozins, yeah. Please check out our heart failure episode if you want to learn more about SGLT2 inhibitors for the use in heart failure.
And diuretics.
So SGLT2 inhibitors are drugs which are commonly used in diabetic patients and heart failure. And they work by reducing the renal tubular glucose reabsorption, which then reduces the blood glucose without stimulating insulin release. Yeah. And for some reason, they're nephroprotective. They slow the progression of CKD, even in patients without diabetes. So SGLT2, I swear to God, they're like the new wonder drug.
Yeah.
They work for everything. Okay. So now we're going to move on to the second category, which is the reduction of cardiovascular risk factors.
Yeah.
So there are 2 which overlap with CKD progression.
Yeah.
What were those?
Glycemic control
Yes.
and blood pressure control.
Yes. Okay. And now what's the third one? So you got BP control, glycemic control. What else control?
Statins.
Yep. Lipid control, right?
Okay,
With statins.
Is the lipid thing because the typical picture of someone with these conditions will probably also have high lipids?
Yeah.
Okay. Yeah. A whole metabolic picture, basically.
Yeah.
So you hit them with the statins.
Yeah.
Gotcha.
So just remember that blood pressure control and glycemic control both assist with slowing CKD progression and reducing cardiovascular disease risk factors.
Gotcha.
Okay, now we're moving on to the monitoring for CKD complications. And there are 4 main complications I want you guys to know. Okay, can anyone think of one?
The urea, right? The electrolytes.
Yeah, so
electrolyte disturbance.
under the category,
electrolytes one?
yeah, electrolyte disturbances.
Yeah.
Okay,
Yeah.
so how would you monitor for electrolyte disturbances?
UEC,
UEC. And what would you look for on UEC?
potassium,
Yes.
sodium, phosphate.
But in particular, you want to look for serum potassium and you want to look for bicarbonate because bicarbonate is an important regulator of acidosis
Yeah,
or
so
alkalosis.
you don't want it to be decreased.
Yeah, so you would say with a UEC, it would look at the serum potassium and bicarbonate levels.
Sure.
Okay, so electrolyte disturbances are done. What's another category of CKD complications?
Anemia. So
Anemia.
full blood picture.
Yep. So what would you look for on a full blood picture?
Look at the hemoglobin levels, for example.
Yes. Yeah. And you want to aim for a hemoglobin level around 100 to 120 grams per liter. Like if it's lower, you want that's the
and then
hemoglobin
also
you
look
aim
for the mean cell volume.
Yes.
to
And
check
why do you look for the mean cell volume?
Because you told us it was not microcytic, not macrocytic.
Yeah.
But normocytic.
So normal mean cell volume, would be a normocytic anemia.
Because if you see a macro or a micro, it might make you suspect is something else going on with their anemia, right?
And that's important in terms of anemia, there are many other causes of anemia. So you want to exclude common non-renal explanations of anemia. And what's the most common non-renal one?
Iron deficiency.
Yeah. Which percent
folates.
says what type of anemia?
Microcytic anemia.
Microcytic. So in terms of ruling out iron deficiency anemia, you want to do an iron studies, which look at the ferritin and transferrin saturation.
Yep.
And what's another thing you want to look at? So you got full blood picture, iron studies, and what's the last one? Which can cause a macrocytic anemia.
Is it B12?
Yes.
Folate and B12.
Folate B12.
Yeah.
Oh, that's
Yeah.
macro.
That's macrocytic, yeah.
Yes. I'm
And
quite
iron
sure
is
that's-
micro, right?
Microcytic,
Okay,
yeah.
okay.
Those are like,
Yeah,
I swear, the most common called, like,
Yeah.
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 Okay.
Yeah. So
Yeah.
full blood picture, iron studies, folate and B12.
Yeah, gotcha.
Okay. So anemia is done,
Oh,
electrolyte
makes sense,
disturbances. We've got 2 more. Okay.
Vitamin D.
Yep. So bone disease.
Bone disease, yeah.
That's what I like.
Bone
Keep nice,
disease.
simple bone disease. Okay. So what would you order to monitor for bone disease?
You'd order the bone studies.
Yep.
So you look at...
So 3 things you want to look at. You want to look at calcium levels, phosphate levels,
Yeah,
and
yeah.
PTH levels because
Yeah.
hyperparathyroidism.
Oh, so
Yeah,
I
yeah,
mentioned
yeah.
this in the wrong category.
I'm not sure
Because
what-
UECs don't measure calcium or phosphate. That's a separate test.
Oh,
Yeah,
so the
so yeah.
UEC looks for
It looks at like sodium, chloride, potassium, bicarbonate.
potassium.
Yeah, but
okay,
it doesn't
yeah,
look at
yeah.
calcium, phosphate.
Yeah,
Magnesium doesn't
Sure,
as well.
sure,
So
yeah.
yeah.
Yeah. So calcium, phosphate, parathyroid hormone.
Sure.
So bone disease, electrolyte disturbances, and anemia
Anemia.
done.
Yeah.
What's the last one? It's the most logical one. You got a failing kidney. What do you
Urine
wanna-
output.
EGFR.
Yeah, you just want to look for declining renal function.
Yeah.
Okay. So you want to look at the GFR and creatinine. I
Yeah.
think those are
Okay.
the 2 main
Yeah,
ones.
yeah, gotcha.
What's another test you want to look at? It's regard to the protein urea.
PCR.
Urine ACL, urine albumin creatinine ratio.
Right. Yeah.
which is
gotcha.
under the protein creatinine ratio.
Yeah.
Yeah.
Okay,
Okay.
so that's an important
Yeah.
investigation to do
Yeah.
because albumin and creatinine ratio is important in the stages as well.
Yeah.
Okay. And the last thing you can do is more of an examination, but blood pressure is an
Yep.
important indicator of renal function.
Sure.
Okay. So you want to do a UEC, urine ACR, and blood pressure.
Might as
Sure.
well do your analysis to check for any
Yeah.
protein
Urinalysis.
urea or any.
That'd be
lipid-
useful, right, if they've
lipiduria.
got any UTI,
Exactly,
which could
yeah, yeah.
exacerbate an AKI,
Yeah,
things
yeah,
like that,
yeah.
right? And that is essentially CKD in a nutshell.
I thought you had 3 categories.
Yeah, slow CKD progression, reduce cardiovascular risk factors, and monitor for CKD complications.
In my mind, I'm just picturing the drop downs and all the different categories.
Well,
That's why.
tell
check out the
you
Notion
that's
document.
how you're meant to think about it, right?
No, you're absolutely
Because by having the drop-down menus
Yeah.
in your head, that's how you'd want to answer
Yeah.
a OSCE question, right?
Yeah.
You'd be like, oh, in terms of medical management, I'd like to slow the CKD progression, reduce cardiovascular risk factors, monitor for CKD complications. In regards to slowing CKD progression, I'd want to manage the blood pressure, glycemic control, as well as reduce protein urea.
That's really good.
I have to apologize for pressing on the diabetes. 'Cause your headings were very immaculate, and I think those are much better than just shouting out diabetes all the
Yes,
time.
yeah.
And the issue is because it's so, I swear, like even me, like when you get asked a question, you jump straight into giving like
For
the
sure.
answer rather than
For sure.
subcategorizing your answer.
Yeah.
Anyway, I'm just going to go through the 3 main takeaways
Yeah.
I wanted you guys to know.
Yeah.
So the first one is that CKD is defined by a low GFR alone or evidence of kidney damage for greater than 3 months. Second point is CKD affects the 3 basic functions of the kidney. And those 3 basic functions are to regulate the concentration of sodium and water, acid and bases, and electrolytes, particularly potassium. The other functions include excretion of metabolic waste products such as urea, hormone synthesis of renin, EPO, and calcitriol. The last point I wanted to make was that medical management of CKD can be broken down into slowing CKD progression, reducing cardiovascular risk, and monitoring for CKD complications.
That's it
all,
in a
folks.
nutshell.
Good. That's it. 3 main takeaways, guys.
3 main takeaways. That's it.
I love how you can say that perfectly. You can't do the intro to this podcast.
I don't, man. I get stressed.
Hey guys, Adian here with some fact checks. Jason states that calcitriol causes calcium release from the bone. This actually depends on the vitamin D levels, as at low vitamin D levels it stimulates bone mineralization, and at high levels it stimulates bone resorption. Jason also states, in regards to EPO levels, in patients with chronic kidney disease, EPO levels are inappropriately low relative to the degree of anemia. Generally, EPO levels are normal or slightly increased in the anemia associated with chronic kidney disease. Thank you so much for listening to our episode this week. To get the most out of this podcast, check out our Anki flashcards and our Notion document. And for all your first principles, keep it right here at 1 p.m.